Hello there, my name's Toby Page. I'm a urology consultant at the Freeman Hospital in Newcastle upon Tyne. I'm going to be talking about what to do with benign histology in small renal masses. Increasingly, we're diagnosing more benign masses due to incidental imaging and an increased use of biopsy. We're actually diagnosing these in younger people, and we're seeing it more in women than men. It's obviously increasing the amount of work that we're all doing and the hospital and for our radiology and administrative departments, and is becoming a growing burden on many busy urologists. What do we mean by benign masses? Here's a list of some of the commoner ones we see. Oncocytoma being seen in about 5%, angiomyolipomas often diagnosed without a biopsy due to their typical appearance on CT scanning or MRI scanning, metanephric adenomas, cystic nephromas, leiomyomas, and then a range of other benign entities such as hemangiomas and stromal tumours. Don't be caught out by cortical adenomas. Although they are adenomas, they do metastasize in at least 60% of cases. Looking at oncocytomas in more detail, these make up a fair proportion of all the findings we see on small renal mass biopsies, but they can coexist with renal cell carcinoma. They can be multiple, bilateral, and they can reoccur. There are a number of genetic susceptibilities such as Birt-Hogg-Doob syndrome and familial oncocytosis, and these patients need to be treated differently if there is a known underlying genetic basis. Angiomyolipomas, often a common asymptomatic finding on renal tract ultrasounds, more common in women. We know that their growth rates and behaviour is affected by hormonal changes, and some of our decision making may be affected by this depending on if a patient's on the pill, if they're planning pregnancy, or if they're postmenopausal. The majority is sporadic, but 10 to 20% can be associated with tubular sclerosis, and patients with tubular sclerosis and angiomyolipomas do need separate management as they behave differently. The vast majority of AMLs do not grow very much, but the growth rate is higher in patients with a genetic susceptibility. Historically, we've used a cutoff of around 4 centimetres for treatment, either embolization, excision, but actually that 4 centimetre cutoff may be quite conservative, and we know the actual risk of bleeding is much lower, with only about 10% of these lesions bleeding when larger than 4 centimetres. Modern imaging with both CT and MRI now gives us much more detail about the ratio of the components of an AML, and that can actually guide us more about whether this is a patient who's at higher risk of spontaneous bleeding or rupture. Particularly, we can look at how much fat and how much vascularity there is. As we know, very fatty lesions with a lot of vessels are at a higher risk of bleeding compared to those with more solid muscular components. Occasionally we do see fat poor AMLs, particularly on biopsies. They're less typical on CT scanning. And be aware of epithelial angiomyolipoma, which is not a benign entity but is malignant and should be treated as a malignant lesion. Metanephric adenomas often present later with symptoms, particularly bleeding and pain. And then we have leiomyomas and other stromal tumours, which often present later, particularly quite large with mass effects, have often been there slow growing for a long period of time. So what can we do? Well, we need to assess the patient. Do they have symptoms? What's their performance status? What's their life expectancy? And we shouldn't use age as in isolation, but look at the patient as a whole. Many octogenarians now can expect 5, 10, or maybe even more years of life ahead of them. Is there an underlying genetic basis for the mass that we're thinking of either treating or surveying? And what's the patient's understanding of what's happening? Are they very anxious about it? Clearly, there is a risk of over-treatment, and that has a cost to the patient with regards health, time off work, morbidity, cost to the NHS in unnecessary operations, and a cost to the environment with equipment and carbon wastage. What about under-treatment? There's clearly a risk in undertreating these patients. We may lose the window for nephron-sparing treatment, and over time, patients who are under surveillance may have a longer period of time with living with symptoms. There's very little evidence in looking at patients on active surveillance for benign lesions, but this study quoted below was not a randomized controlled trial and clearly demonstrates some bias in the selection of those who had active surveillance versus immediate treatment. But in those patients who did have active surveillance, over time they had a higher functional decline in their renal function overall. But this probably suggests selection bias rather than anything else. What are our options? Well, we can treat the patient immediately after they've had their biopsy and we've found out they have a benign mass. We can have a period of surveillance, or perhaps the most importantly, we can discuss discharge and actually discharge them without any further follow-up. If we treat now, then obviously if it's a large lesion, we're going to need radical treatment, particularly if it's bleeding, if there's clinical doubt or there are multiple lesions. Or we can consider minimally invasive treatment just like we would for a malignant lesion, depending on size, position, multiplicity, and the genetic basis of the growth, particularly in patients who we know are likely to get further growth, such as patients with tuberous sclerosis or Birt-Hogg-Dube syndrome. Then there is definitely going to be an argument for earlier minimally invasive treatment to try and preserve good nephrons. We can think about prophylactic treatment in angiomyolipoma, and other things in angiomyolipoma that can trigger prophylactic treatment is the presence of aneurysms over 0.5 centimetre. What about surveillance? Well, we need to look at the patient. What's their life expectancy and performance status, and does it warrant a period of surveillance? There is no point in monitoring a patient's renal mass if they are never going to have treatment due to their underlying comorbidities. If we do think we're going to embark on a period of surveillance, we need to pick the least costly, both in patient time, our time, the least expensive with regards to the cost of the actual investigation we're going to do, and also consider the overall health of the population, not the individual, looking at the cost with regards sustainability and carbon output. We don't want to have too frequent surveillance. It makes work for us, it's inconvenient for the patient, and it's costly. And it's very useful to define the plan for surveillance at the outset. For example, saying to a patient, we're going to scan you 1 year, every year for 5 years, and if it hasn't increased very much in size, we will discharge you at 5 years. Telling a patient this from the outset makes that discharge conversation down the line that much easier. Here's an example for a patient with sporadic angiomyolipoma. If it's less than 2 centimetres, primary care ultrasound at 1 year and 2 years, and then no change, and discharged would be very reasonable. If it's larger than 2 centimetres, multiple, or there are some other concerns, then an individualised plan for how we're going to follow this up, avoiding ionising radiation, is very important, and that might even include some decision making based on the CT appearance at the time of diagnosis. We need to remember actually only just over 10% of AMLs will show any growth change, and the bleeding risk, if we look at all AMLs, is low, around 2%. Patients with tuberous sclerosis need a different regime. There's a consensus agreement that they should have non-ionising investigations, certainly every 1 to 3 years, depending on their age. With regards to oncocytomas, they demonstrate very variable growth rates between nothing to 5 centimetres a year. Mean growth rates in a number of publications don't agree and are widely varying, but it would not be unreasonable to suggest an early ultrasound scan 6 months after diagnosis, and then yearly for a number of years, either 3 or 5, before then suggesting discharge if the oncocytoma has not demonstrated any significant growth. If we look at EAU guidelines, they do suggest that it's safe for selected patients to follow them up and not treat them immediately, but they do suggest treatments for triggers of size over 3 centimetres, which we could debate, or a growth rate of over 0.5 centimetre a year, or if a patient develops symptoms. Perhaps the most important and sometimes the most difficult conversation is about discharge, and this is a viable option for many. Many patients will be comfortable with discharge and it will allay a lot of their anxieties, but we may do this after a period of assessment of how a lesion is growing and its growth kinetics. Some patients, however, even if they know it's a non-cancerous benign lesion, will find discharge a difficult concept. What about the cost of all of this? Well, the cost to the NHS, surveying a lesion and then discharging it is still the most cost-effective option, although it does involve more follow-up, administrative and burden for the patient in coming and going for multiple investigations. For the planet, we know the NHS is a high producer of carbon dioxide, and we need to perhaps start thinking about our responsibility with regards to that and how we can play our part in decreasing the amount of CO2 that the NHS as an organisation produces. Overall, the NHS produces more emissions than all the aircraft going in and out of Heathrow Airport. So in conclusion, we need to think about individualised care-based discussions on how we're going to follow these patients up. Patients with poorer performance status, low functional reserves, lots of competing morbidity are probably best discharged as they're unlikely to ever require any treatment. Growth kinetics and initial size of a lesion are poor markers for intervention, and there's very little evidence on the impact on patients' quality of life and the effects of surveillance or treatment on their anxiety and overall function. Thank you.